Hi everybody, and welcome to this session arranged by the Anaphylaxis campaign on the latest issues in allergy and anaphylaxis. My name is Dr. Helen Howells, and I'm a GP with an extended role in allergy. These are my disclosures. So as you can see, I'm sponsored by a variety of different people to give up my time to educate, and I'm also a trustee for the Anaphylaxis campaign. So I am a GP working in the Dorset area, and I have a couple of roles with that. I'm a frailty visiting GP, and I also work for the 111 service in the urgent treatment centre. And it's in that role that I tend to pick up quite a lot of allergy that's either presenting acutely as an emergency with an allergic reaction, or not unusually, I may pick up missed cases of allergy. And the reason that I became interested in allergy is because my eldest son, Ethan, had milk and nut allergies when he was little and suffered with anaphylaxis. And I realised I just didn't know enough about the topic. So I went on and did the Masters in Allergy at Southampton University and worked with the paediatric allergy team at Southampton for 4.5 years. Whilst I was in that role, I was the chair for the primary care group of the British Society of Allergy and Clinical Immunology. And now with some struggles with funding of working in the NHS, and because waiting times are so huge, I've set up my own private clinic, Dorset Allergy, to see children and adults struggling with allergies locally. And I'm also the trustee for the Anaphylaxis campaign. And then sometimes I see our 5 children, but they always whinge at me that it's not enough. So in this session, what we're going to do is have a look at the differences between food intolerances versus IgE and non-IgE mediated food allergy, and have a look at how we recognise those, think about anaphylaxis, how it presents, and when you may need to prescribe an adrenaline auto-injector. And then we're going to have a brief look at COVID and flu vaccinations and allergy. So food allergy is incredibly common. And it affects anywhere between generally thought to 2 to 5% of infants and children. And therefore, just that number alone tells us what a large abundance of work we will be provided with in primary and secondary care. But actually, this study is showing that it's a bigger problem than just that. So this is data from the Prevalence study, which shows that about 25% of parents and caregivers believe that their infant has a food allergy. And if you think about it, that's really more reflective of the work that we would see in primary care, because all of those people are likely to present to us concerned that their child has a food allergy. And it's going to be down to us to unpick, do they or don't they? And which of these do we need to think about referring on to a specialist clinic? Because actually, in actual fact, when you take a good allergy focused history, then that number goes down to more likely 16% of infants will have a food allergy. And when you then actually go on and do a food challenge and see who is actually allergic to the food, then the numbers are more like the 5% that we would expect. And really it's that 5% which we're thinking about referring on to an allergy clinic and hopefully managing the rest of them in primary care. But that's not always as easy as somebody might think. So here's some useful definitions for you to help guide your parents and patients as to who does have a food allergy, and if they don't, why they don't. So hypersensitivity is just the umbrella term that we use to refer to any unpleasant but reproducible reaction to food. And then I explained that we call it a food allergy if the immune system has become involved. So it's an adverse reaction from a specific immune response. And we will be able to tell that based on the timing involved in allergic reactions, the signs and symptoms that present, and the reproducibility of the reactions. And if those features aren't there, then we can say, look, it's not a food allergy because he doesn't have these signs or symptoms, and therefore it's more likely an intolerance. And because it's not a food allergy, then you or your child is not at risk of anaphylaxis, so you don't need an adrenaline auto-injector. And this is how we're going to manage it instead. And I always explain that the challenge we have is that the medical definition of intolerance is a reproducible adverse reaction to something, to food usually, that doesn't have an established immunological mechanism. So for instance, lactose intolerance is due to a deficiency of the lactase enzyme. It's a very definite thing. It will give reproducible symptoms of bloating, tummy pain, diarrhea, that obviously are significant for that person. But the challenge we have is in today's society, we use the word intolerance in a very dismissive sense. So we say, oh, you know, they're just intolerant to everything. And I explain that the true medical definition is a reproducible adverse reaction to food. You know, that this is definitely happening to you or your child. We understand that that has consequences for them, is unpleasant, and we do believe you that it's happening. It's just not allergy because of X, Y, and Z. And sometimes you can tell them the mechanism involved in their intolerance, and sometimes we can't. And that just helps people feel like you're listening to them in your consultation and that you believe them. And then they're much more likely to understand and believe you that it's not allergy, because it can be quite hard to take that label away from somebody. People do think it's easier really to be labelled with allergy rather than have unexplained reasons as to why they get these reactions. So to help us, NICE have defined the different signs and symptoms associated with IgE and non-IgE mediated foods, and they've put it into different organ groups, so skin, gastrointestinal and respiratory. So if we look at IgE mediated with skin, then we get pruritus, so itching, erythema, which of course is redness, urticaria, which is hives, and angioedema, which is swelling. And the hives tend to occur in quite a classical pattern, so they tend to be smaller and they often start around the mouth where the food has gone in, and on the hands where you've had contact reactions, and then will often spread out across the body from there. As opposed to urticaria that may present from something like a viral illness or spontaneous urticaria that tend to be larger plaques and often start across the trunk and then may spread all over. So just one of the ways of trying to differentiate, is this an allergy or is this another process going on? When we are looking at non-IgE mediated allergy, the bulk of the work that we're going to see in primary care is something that's going to affect infants. So they tend to present in the first 2 to 3 months of life generally, and the commonest things that they will have a non-IgE mediated allergy to would be milk and soya. If they're exclusively breastfed, then they may present a bit later at the time that either formula feeds are introduced or that they're perhaps weaned onto milk, so maybe at about 6 months, but generally these present early in life. There are other less common forms of non-IgE mediated allergy, such as eosinophilic esophagitis or FPIES, which is food protein induced enterocolitis syndrome. But you may have never heard of them because they're not that common, and they tend to have a more insidious onset and often are picked up by secondary care really. So the bulk of the work we're going to be seeing is in the little ones. And when we look at the skin, they get pruritus, erythema, and eczema. But here I just want to touch upon the important factors to do with their eczema. So whenever anyone has eczema, then their family or the patients always believe that the eczema is caused by something. And people will usually look to see what foods are triggering my eczema. And sadly, in a sense, that's not the case. It's not easily resolved like that. So when you have eczema, that is the first thing you have. That's your original condition. It's due to a mutation often in the filaggrin gene, which means you have a defective skin barrier and your skin dries itself out easily. And when you have eczema, you are at higher risk of food allergy, particularly IgE mediated egg and peanut allergy. And then you can have other food allergies arise, but they do not cause your eczema. So even if you take out the foods that you're allergic to, you will still be left with eczema, sadly. And there are lots of reasons eczema flares, so stress and illness, and if you're exposed to the food you're allergic to, you'll still be left with the eczema. So even in these little ones, they present early with eczema, and often it's very difficult to manage eczema. So even with good use of emollients, appropriate use of steroids, it may not get better. And they may then find that when you remove the food that they're allergic to, like milk or soya, that their eczema gets better, gets much more manageable with the appropriate treatments, or it may even look like it's resolved, but then it's not unusual that it will creep back a few months later or a year or so later. And again, people will start to then go, why have I got eczema now? What else am I allergic to? And the answer is nothing. It wasn't the food causing your eczema in the first place. It was just making it hard to control. And that's really important to remember for when you're trying to help people manage their eczema. It's important not to cut foods out willy-nilly in eczema, because otherwise you can trigger allergies to form. When we look at the gastrointestinal system for IgE mediators, so they may get swelling within their mouth, their lips, their tongue, their palate. It's quite often that they get itching within their mouth if they eat the food that they're allergic to, so the allergen they're allergic to. And little ones might often say that food tastes spicy or spiky, and that's them telling you that their mouth doesn't feel right. and they get immediate onset of tummy pain, vomiting, diarrhea. With non-IgE mediated allergy, you can see this is a very gut-heavy illness. And you can look through the list and go, well, okay, but how many normal babies do I see that may have colic or constipation or a bit of reflux? And how do I work out if that's allergy or whether it's just normal baby or a functional gastrointestinal disorder, which is essentially something that happens to over half of infants. Kind of normal, there's no structural or biochemical problem, and is something that will resolve as they get older. And the key really is that these babies with the allergies will have multiple symptoms, often across different systems. So they'll have eczema and reflux and constipation. And it's putting those whole host of symptoms together that make you concerned about allergy rather than an individual symptom. So we divide this into upper and lower gut symptoms. So for upper gut, you're talking about reflux, vomiting. These babies are often very unsettled and cry for hours and hours of the day. So it's useful to say how many hours this baby cry for. And if they say, 2 or 3, then you're going to be thinking, okay, it's probably normal. But if they're saying 12, 14 hours of the day, then clearly that's not right and makes you much more suspicious. For lower gut, they may have lots of loose explosive nappies that people describe as punamis, or you may find that they have blood in their stool if they're breastfed or combined feeding, but for reasons we're not quite sure why, it doesn't happen with purely fed, bottle-fed babies. They may get mucus in the stool, or they may get soft stool constipation. So they strain, and when they do go, the stool is soft rather than hard. And you may notice redness around the anus. And in time, sometimes these babies will start to refuse formula or breastfeeding. And if that happens, then you may well notice an impairment in their height or their weight. And it's important to get both the height and weight checked because often what we find in allergy is the height is impaired first before the weight. So it's important to check both. And the other thing we must do is recognise that mild to moderate allergies wouldn't involve impairment of height and weight. So just because baby may well be growing well doesn't mean that they can't have an allergy. It doesn't mean that that's not going to have a significant impact on that infant and their family and should still be treated appropriately. It just takes it away from more severe disease. So please don't falsely reassure families that there's no problems just because their height and their weight are okay. And then finally, when we're looking at the respiratory system, for IgE mediated, they may get what essentially looks like hay fever when they're exposed to the foods that they're allergic to. So runny nose, runny eyes, congested, sneezing, or signs of anaphylaxis, so breathing difficulties, coughing, wheezing. And according to NICE, there are no respiratory symptoms associated with non-IgE mediated allergy. But actually, if you look at the MAP guidelines or IMAP guidelines, which are the International Milk Allergy for Primary Care guidelines, they do notice that these babies are often quite congested and snotty. But if that's all the baby has, so they're just snotty, then please don't diagnose them with a non-IgE mediated allergy. It is usually in conjunction with the other symptoms that we discussed. So the commonest way these babies with non-IgE mediated allergy will present are a crying infant consultation about their bowels, either constipated or loose, reflux, eczema, or snotty baby consult. And if you get used to, whenever you get one of those consults, just running through, okay, if it's about the skin, what are their bowels like? Do they vomit? What's their height and weight? How long do they cry for? What, have they got any respiratory symptoms? Then you will not miss this condition. The challenge with non-IgE mediated allergy is it is very hard to diagnose. People often present multiple times before their little ones are diagnosed, which causes a lot of upset. And you need to have it on your radar. The other issue is that there's no test that exists to diagnose non-IgE mediated allergy. And so no easy answers. What we would recommend is that you cut the food out for 2 to 4 weeks. You see, hopefully, if it's allergy, that the symptoms go away. And then to confirm that it was definitely that food that caused the problem, you need to put it back in, even if it's just one formula of cow's milk or one breastfeed where mum's put milk back in her diet. If the symptoms then all come back, then you've got your diagnosis of non-IgE mediated allergy. But you must do the retrial, otherwise you don't have the diagnosis. Now moving on to anaphylaxis. So this is one of the definitions that we use, but the definitions do vary from country to country or society, which can mean tracking rates can be a bit challenging, but generally this is a well-recognised definition of a severe, life-threatening, generalised or systemic hypersensitivity reaction. and this lovely poster from the Anaphylaxis campaign telling you what to look for and what to do. So we think about A, B, C symptoms. So A for airway. And this is actually one of the ways that my little man presented first off with anaphylaxis, and ashamed to say that I didn't recognise it was anaphylaxis because I didn't recognise the more subtle signs of how it can present with a persistent cough that may sound like your throat clearing, so but it goes on and on and on. Or their voice may change, so their cry might get hoarse, their voice might get hoarse, and of course more obviously they may get swelling within their mouth or be dribbly. And those things, when they happen, imply of course bronchoconstriction, airway narrowing, and of course breathing difficulties. But for me, I was looking at a person with anaphylaxis being collapsed on the floor, which actually obviously is more severe. B for breathing difficulties, so wheezy, noisy breathing. You may notice that they have a drop in their saturation levels. And C for conscious or circulation problems. So older people may tell you they feel dizzy or faint. Young children may just go floppy. They may look pale, be clammy, and you may then notice on the worst end of the spectrum that they are tachycardic, have a drop of their blood pressure, and of course may well collapse. What to do? So if someone's having anaphylaxis, one of the key things to remember is that we shouldn't move them. Now, obviously, if you've got a toddler, you're just going to have to go with the flow. But for an older person, you ask them to stay still. If they have breathing problems, then they should sit up. But if they don't, they should lie down and lift their legs up. And if you have been issued an adrenaline auto-injector, or they have, then you should give that into the thigh. And after you've given it, you ring 999 and you say that this person is suffering with anaphylaxis. And that should prompt an urgent response. Obviously, if you don't have an adrenaline auto-injector, then you ring 999 straight away. After you've given it, if after 5 minutes things aren't better, then you give their second adrenaline auto-injector that they should be carrying, and you give it into whichever leg you can reach. So if you only can get to one leg, that's the leg you give it to. If it is easy to put it in the other thigh, then we would recommend it's put in the other thigh. And that's really just based not on evidence, but more sort of scientific thought that you'd think if adrenaline causes vasoconstriction, it's probably better it goes in the other thigh so that there's good sort of blood flow to take up that adrenaline to get it acting. So most allergists would recommend we give the second adrenaline auto-injector into the other thigh. But if you can only access the thigh that's nearest you, then you just put it in that one, and that's fine too. These are the foods that commonly cause food allergy. So egg, milk, peanuts, tree nuts, fish, shellfish, soya, gluten and wheat. And that causes 90% of food allergies. And we do see lots of other things emerging. So we see lentils, sesame, kiwis. As people have become gluten and wheat free, they tend to just replace the flour to make bread with things like lupin. So now we see more lupin allergies emerge. And I've been hearing from my colleagues that as people have become meat free and are looking for substitutes, that we're seeing more things like jackfruit allergy emerge, which is something that traditionally we never really ate in the UK. But as we're now looking at these alternatives, we are seeing these newer allergies arise. The reason I mention it is because if somebody is coming to you, then you always have to sort of think about how likely is it that the person in front of me is describing a reaction to food. And if you have a mum coming in saying that this baby's weaning and looks like they've reacted to scrambled egg, it's going to be quite high on your radar to be suspicious that that sounds like an allergy, given egg is common, that weaning age is a common time to start having reactions. If you have a 30-year-old, say, come to you that's got no history of atopy, so no eczema, asthma, hay fever, food allergies, and suddenly has an allergic reaction, and they normally eat everything and they can't figure out what it is, so they've been looking at the packet and trying to randomly search through, what might be the additive I'm allergic to or the E number, then that's going to go much lower down on your index of suspicion. It's probable that actually they're going to have something else going on, like a spontaneous reaction or a reaction that was triggered perhaps by a virus. Not necessarily, you need to take a clear history, but it just helps you differentiate and weigh up what's the probability of reactions. So we're going to have a look at a case history for you now and work through that. So Flora is 9 and brought by her parents who are worried that perhaps she's got a peanut allergy. She used to eat peanuts regularly as a toddler, but then she became a bit fussy and she stopped eating them and hasn't knowingly eaten them until yesterday when she had a chocolate bar that contained peanuts. And they tell you that within 15 minutes, she developed urticaria around her mouth and angioedema of her face, and she vomited. And then when you actually specifically asked mum about coughing and hoarseness, she said, oh, yes, she was coughing, and her voice did sound a bit different, actually. Mum gave some cetirizine that she had in the house, and her symptoms all went away after half an hour. And actually, when you ask about Flora's atopic history, she has well-controlled eczema and asthma. And when we look at family history, we just want to know about first-degree relatives, so siblings and parents. And actually, Dad has asthma and eczema, and Mum has hay fever. So quite a strong family history of atopy there. So hopefully from that, you're thinking to yourself, okay, this sounds quite likely that Flora is allergic to peanuts and has had an IgE-mediated reaction. And just to remind you, that's because when we're looking at the skin, she had the urticaria and the angioedema. For the gastrointestinal, she had vomiting. And then when we actually asked about symptoms of anaphylaxis, rather than just say, did she have any breathing problems, which people often say no to, when you specifically ask about airway involvement, they often say yes, which is what Flora's family did. When we're looking at timing involved in IgE-mediated allergy, because the immune system is primed and ready to go against the allergen that you're allergic to, usually it happens within minutes of eating the food, certainly up to an hour or two after exposure, and usually it's fully resolved within an hour or so. You can, of course, have a late phase reaction, which typically is about 6 hours later, but that is less common. But so mostly you need to know that it comes quickly and it goes quickly. So if someone says to you, well, the reaction occurred the next day after eating a food, or the symptoms were there for a week, then you can say, well, this isn't food allergy then, because that actually timing wouldn't be right for food allergy. And it's much more likely that a virus was triggering your symptoms, or you've got spontaneous urticaria. And the other thing, sorry, there is about reproducibility. So the reaction would occur every time that you eat the food. The reason it hasn't happened with Flora is because she had a long period of time where she didn't eat peanuts, and therefore she lost her tolerance to it. And we particularly see that in children with eczema. So there is good evidence from things like the LEAP study to show that peanuts and eggs should be introduced early in life before the age of 1, particularly in children with eczema. And then they need to eat it regularly 2 or 3 times a week to maintain their tolerance to it until at least the age of 5. So that didn't happen to Flora. And because that didn't happen, it allowed allergy to form, so that when she then ate it again when she was older, she unfortunately reacted. And that's a classic history, to be honest, with peanut allergy. We very often hear that story. So how do we go about confirming an IgE-mediated allergy? Well, the only validated tests are skin prick tests, specific IgE tests that used to be called RAS tests, but are now called IgE tests, or a hospital food challenge. What we should not be doing is using any of these other methods. So a patch test is used by dermatologists to diagnose type 4 allergic reactions, which are those more delayed skin reactions. They're not used for IgE-mediated allergy, which is a more immediate thing. IgE blood tests IgG blood tests are often done by non-specialists, non-medics on the high street, or by pharmacists, that you sort of send it away from a pharmacy rather than pharmacists themselves. And so if someone's coming to you with those blood tests to say, look what I'm allergic to, if you see that it is an IgG test, then that is not a validated way of defining allergy. And the other thing that some of these people on the high street will do is a hair analysis, kinesiology, or Vega testing, where you essentially hold a bar and see what you're allergic to. And they're always told really to exclude things that cause irritable bowel. So wheat, dairy, broccoli, garlic, spices. And that may be okay for an adult to do that, but I have really big concerns when children are being told to exclude those foods based on no science, because then they have real risks of growth impairment, of nutritional deficits. So we should be explaining to people that these are not validated forms of allergy testing, that they shouldn't be excluding foods based on that. And there's a really useful leaflet you can give them from the British Society of Allergy. The link's there at the bottom. So I'll talk more about those tests in a minute, but the purpose of this slide is to explain really why we just shouldn't be doing allergy tests on everybody. Everybody thinks they want allergy tests. They always say to me, oh, I'd love to know what I'm allergic to. And I'll explain to you why it doesn't quite work like that. So when the body is exposed to allergens, so things that we could be allergic to, it's through one of 3 ways. So either through the gut by eating it, through that defective skin barrier that we talked about with eczema, or through inhaling it. And when the body's exposed, then it will do one of 3 things. So, for instance, somebody will tell you that they eat peanuts all the time and they have no IgE symptoms, so no hives, swelling, vomiting, anaphylaxis. And you check their blood test, so IgE to peanut or skin prick test to peanut, and it's negative. And that's lovely. There's no history of reaction, no tests showing that there's any possibility of allergy, and you put them together and there's no reaction. On the opposite end of the spectrum, you have someone like Flora who tells you that when she eats peanuts, she gets hives, swelling, vomiting, anaphylaxis, and you check her IgE or skin prick test and it's positive. And it confirms what we were already suspicious of, that she was allergic to it. The challenge we have is with the group in the middle who are what we call sensitized. So they produce enough IgE to give them a positive test, sometimes really high numbers, so they can have IgE of over 100, but who are not necessarily allergic to it, so don't describe any clinical response. So I'll share a story. So I had an older child, or she was a teenager, she was 14, referred to me in clinic by a dermatologist. She presented quite late with eczema. So the dermatologist had done a panel of foods to see what she was allergic to that might make her eczema challenging to control, or of course the eczema. Now, IgE blood tests or skin prick tests are only done to diagnose IgE-mediated allergy. And if you remember that first slide about the skin, eczema is not an IgE-mediated symptom, so shouldn't have actually been done. And as I've also said, food allergies don't cause the eczema. So really, it was not something that I would recommend to do for someone that's older with eczema. Anyhow, it was done and it showed that it was positive to all the nuts. So she was referred to me and told to not eat nuts. So when I saw her, I said, have you ever eaten nuts? Hazelnuts, Brazil nuts, almonds, peanuts, etc. She said, oh yeah, I used to eat them all the time. Oh, did you ever get hives, swelling, vomiting, diarrhea, hay fever type symptoms, anaphylaxis? Like, no. And so she described no IgE symptoms. And all that blood test had shown was that she was sensitized to the nuts. Therein, we then had a problem because she hadn't eaten them for months while she was waiting for the referral. And there is a chance then with a person with active eczema that if you're not eating that food and you have a positive test to it, might you have lost your tolerance to the food and become allergic. Now, I asked her to put all the nuts back in one by one because our wait for a food challenge was very long. And thankfully, she was able to tolerate them all without issue. And her eczema didn't change, as I wouldn't expect it to. And it just showed what she was sensitized to. So you have to be really careful. And I really encourage, particularly those in primary care, to only do blood tests when you are just wanting to confirm what you're already suspicious of, really. Or if you want to have a look at, what's causing your hay fever, grass pollen, tree pollen, cat, dog, that's fine. But for foods, it should only be done in conjunction with the history. If you get people to cut out foods based purely on a positive test, then there is a risk that you will cause problems. And equally, on the other end of the spectrum, if you have someone that has a really clear history of an allergic reaction, but their tests are negative, then they should be referred on to secondary care for more investigation, because sometimes you get false negatives as well. So in the community, we can do specific IgE blood tests. They come back as a grade 1 to 4 and as a number, but all you want to know is if it's over 0.35 and you've got a good history, then it's positive and it confirms allergy. The higher the blood test result, the higher the skin prick test result does not dictate how likely it is that somebody's going to have a severe reaction. Unfortunately, we can't predict that. So my own son with his milk allergies, his IgEs used to be something like about 6. But he had several episodes of anaphylaxis. So the higher the number does not dictate the severity of a reaction. We use it to look at how likely is it that that person might outgrow the allergy, are they improving with time, but we don't use it to predict severity. Skin prick tests are lovely and easy to do, but obviously usually only accessible in community allergy clinics or secondary care. They take about 15 minutes. You have little vials that contain different solutions. So you put little droplets of things like cat, dog, peanut, milk on their arm, and you prick it with a lancet so it feels a bit like you've poked yourself with a sharp pencil, and you wipe it away and you leave it 15 minutes, and you're looking to see do they get a raised bump there. And if it's over 3 millimeters, it's said to be positive. It's quite nice because if you want to test something a bit more unusual that you haven't gotten as a solution, you could prick that substance, say a kiwi, and prick their skin, and that would work just as well. And patients like it because they get results on the day. So they get essentially a one-stop clinic. So they have a history taken, test done to confirm what the problem is, and then a management plan from there. And it works well on children, infants, and adults. There's no lower age we can do it, but obviously the person has to be eating the food or about to be eating the food, otherwise it's irrelevant. So we wouldn't test nuts, for instance, on a 1-week-old because they're not going to be eating those things and things can change. And I have found that it's not particularly helpful for perhaps those with sensory disorders like autism. Then those children often don't really like it very much. And the other thing, that if you're having a skin prick test, you must stop your antihistamines for 4 days before the test, otherwise you can get false negatives. And that's not true for a blood test. So you can have a blood test done while someone's on antihistamines and it won't affect the results, just for the skin prick tests. And then the final validated method of testing for food allergy, and the gold standard really, would be to do a food challenge. So somebody goes into hospital for half a day, and the aim of it is that by the end of a morning or an afternoon, they'd have had a portion of whatever you're testing that would be appropriate for their age. So the right amount of peanuts for a 2-year-old that would normally consume, say. You give a small amount to begin with, and after 15 to 30 minutes, you look to see do they react, and if not, you give a bit more, and so on and so forth. And the nice thing is it's done in the safest environment possible. And if they do react, then you can either give them antihistamine, but if we needed to give them adrenaline, then if they are old enough, we would encourage the person to give them themselves the adrenaline auto-injector, so they get used to giving it to themselves in a supported environment, or we would ask the parent to give it to the child, and again, so that they gain that support. So it can be a really useful learning experience. 3 reasons that we tend to do it. So 1, diagnostic. So perhaps, like I say, if somebody had a really good history but negative tests, we might do a food challenge to say, were you or weren't you allergic to it? A demonstration. So if somebody did used to have a peanut allergy and now all the tests are negative and we think perhaps they've outgrown it, then we would do a food challenge to check that they're safe before we say go on and eat it at home. And then finally, the rarer time that we would do it would be a demonstration challenge. So this is usually done on teenagers who perhaps don't believe that they have an allergy. And that usually comes about for 2 reasons. Either that they've never had an allergic reaction, they've just always had positive skin prick tests or blood tests, so we've never let them eat it because we were strongly suspicious they'd be allergic to it. Or they did react, but when they were so young that they don't remember the reaction. And now we as allergists are thinking, you know, I do think there's a strong chance that you're still allergic to this because the tests are still strongly positive. And we might be getting from them, well, I don't really think I am. And we might think that they're going to go out and start eating that food in a sort of more risky environment, when they're potentially then not safe if they have a significant reaction. So then with careful consenting, we might agree that they come in, and either, you know, they might be right and they would just have falsely positive blood tests, they would just sensitize and they might pass the food challenge, which would be amazing. Or more often, to be honest, they would then potentially react, but they're in a safer environment that we can then treat them appropriately. They can then learn from that, recognize what the reaction would feel like, and hopefully then take the recommended safety precautions moving forward. So thinking back to our case of Flora with her peanut allergy, do you think that Flora should be prescribed an adrenaline auto-injector? And we have 3 available. We have Jext, EpiPen and Emerades. And the Jext and the EpiPen come in the 150 microgram and the 300 microgram dose. And Emerades only at the moment come into the 300 and the 500 microgram doses. And we'll talk about that in a minute. And the answer for Flora is yes, she should. Reasons. So these are the British Society of Allergy guidelines for prescribing adrenaline auto-injectors. It's a flowchart that looks a little bit confusing, but essentially, if you've had anaphylaxis to food, or spontaneous anaphylaxis, or anaphylaxis to insects like bee and wasp, then you should be prescribed an adrenaline auto-injector. The other time you definitely should is if you have asthma and IgE-mediated food allergy. We know that you are at higher risk of anaphylaxis, sadly, and you are more likely to react if you're exposed to the food that you're allergic to on a day that your asthma is badly controlled. So it's really important for us in primary care to make sure that people are having good management of their asthma, understanding why, not only from an asthma point of view, because asthma still kills, that they need to control their asthma, but also because it puts them more at risk with food allergies. So given that Flora did have anaphylaxis symptoms, and if you remember she had asthma, she has 2 reasons of why she should be given an adrenaline auto-injector. So just to talk through that, so if you've had anaphylaxis, some of these more rarer conditions such as exercise-induced anaphylaxis or spontaneous idiopathic anaphylaxis, they should be given it. If you have asthma with IgE-mediated food allergies, venom allergies with a systemic reaction, or again, these rarer mast cell disorders, then they should be given an adrenaline auto-injector. Then there's a group in the middle that you're a bit like, maybe you do, maybe you don't. And to be honest, prescribing is like prescribing anything. It's a conversation to be had. If someone is saying to you, I don't care what you say, I'm never carrying it with me, then you could argue, what's the point in prescribing something that somebody's not going to carry? You have to make sure, of course, that you've explained to them clearly why you feel that they should carry it, what the risks are to them, and that they shouldn't just be leaving it in their bedroom or in their car. But if they absolutely don't want one, or sometimes I don't necessarily give it if it's going to make someone's anxiety out of control, then, you know, it's conversations to be had. On the other end of the spectrum, if you've got someone saying, I can't eat out because I'm so anxious, or I won't go to parties, and it would just make me feel better if I had it with me, then I think there's a really good reason to be prescribing them for quality of life. You know, adrenaline auto-injectors are about £35 each. We recommend 2. It's not that expensive in the scheme of things when you consider other things that we prescribe for on the NHS. So these are indications of when we'd consider it. So teenagers, young adults, sadly, we know that they are at higher risk of death from anaphylaxis in the kind of 19 to 25-year-olds. And therefore, we often think about it for them. It's not just about risk-taking behaviours, although they are more likely to perhaps go out and drink or maybe take drugs, maybe then not recognise that they're having allergic reactions early, or take more risks. But there are other factors that also we don't fully understand yet as to why this group are at risk. People with peanut tree nut allergies always used to be at higher risk of death, sadly, from anaphylaxis. Actually, that has changed now in that milk is a higher likelihood of death for our little ones, but these guidelines are from 2016. So we, certainly when I worked in Southampton, if we had a child of school age with a nut allergy, we would recommend they carried an adrenaline auto-injector. And then if you've only ever reacted to trace amounts of food, or you're going on holiday to the middle of nowhere, again, those are people that you may well consider might be sensible to have adrenaline auto-injectors. You don't need it if you've had a bee or wasp sting allergy and you've had immunotherapy, so you're no longer allergic to it, you wouldn't need to carry it. The easily avoidable food, I personally think, is a bit tricky because some foods are hidden, like kiwi is often used as a glaze on pate. It's not that easily avoidable. It's not written in bold on the backs of packets, and therefore you might not recognise it. So again, conversations to be had with people as to whether they should or they shouldn't. But you wouldn't need an adrenaline auto-injector for any drug allergies. And the reason for that is, if you think about it, we never prescribe somebody something without asking first, are you allergic to it? Well, we certainly shouldn't. So they would say, for instance, say someone with penicillin allergy, so severe that they were on intensive care because of their allergic reaction. They would say, please don't give me penicillin, I'm highly allergic to it. You won't give it. If they ever collapsed on the street and a paramedic came along and thought this person's having meningitis and I need to give them penicillin, then they are then in an environment where hopefully that paramedic would recognise that this person's having some sort of allergic reaction, but also that the adrenaline would be available. So there's never going to be a time that a person with a drug allergy is going to need to carry an adrenaline auto-injector. I would recommend they wear an alert bracelet if they are severely allergic, but wouldn't need the adrenaline. So things that we should tell people with IgE-mediated allergies. So we need to give them information about food labelling, about how to eat out safely and travel, how to recognise and treat allergic reactions, as I've touched upon, the importance of good asthma control. And personally, I always give them links to other information sites that are helpful. So of course, the Anaphylaxis campaign charity, the Allergy UK charity, they have useful fact sheets on there, useful information, support groups, helplines that people can ring to get accurate advice. So always give them that information. If you go to the British Society of Allergy website and in the search engine type in action plan, you will find 4, one for EpiPen, one for Jex, one for Emerade, and one for no adrenaline auto-injector. Currently, they're only written for children, but so I just print them out and use the same for adults because it is the same concept. And you put in their name at the top, what they're allergic to, their details. You can sign it at the bottom, which then means that they can carry their adrenaline auto-injectors on board, but also give them into schools or nurseries. It reminds them what a mild to moderate reaction looks like and what antihistamine to take that you should prescribe. And usually if they're less than 2, we would give Puriton, but anyone over 2, then cetirizine is a much better antihistamine with less side effects. It reminds them of those ABC symptoms that we talked about. And if they've been given an adrenaline auto-injector, then it will remind them briefly how to use it. So it's really good, and people like it because it's kind of in an emergency. What was I meant to do? Then they've got it there and it can help them stay calm. By law, the main allergens, so to speak, are written in the back of packets in bold. You can see, you might look at these and think, okay, what's sulfur dioxide? So sulfur dioxide is not actually a trigger of food allergy. It causes chemical reactions, but it has been included. And some things like mustard and sesame are common things to be allergic to, but not as common as other things, but they've just been chosen and they're written in bold. So I say to families, always check the backs of the packets, even if you've eaten it before, because of course manufacturers can change what they put in it. If you're in a restaurant, always ask to see what the ingredients are. They will have it, even if it's behind the counter. And just make sure you're happy that restaurants have got good safety measures in place so that they're not mixing chopping boards, they're not mixing spoons, you're not having someone that's chopping up nuts on one chopping board and then using the same knife to chop up your food. So just simple safety precautions that you just want to make sure that they're following. And being cautious in places like bakeries and ice cream parlours if you have nuts and milk allergies, because there's a lot of cross-contamination that can happen. And there's some useful apps that dietitians often recommend. So one called Food Maestro that you can have for IBS with FODMAPs, but there's one specifically for allergy, and Spoon Guru. And what you essentially do is you write in the foods that you're allergic to, and then if you're looking for something like bread, it will tell you which products are safe for you to buy. That's quite useful to know. And now there's a new law that came into place on the 1st of October last year called Natasha's Law. You may have heard of Natasha. There was a lot of press around her death. Unfortunately, she was allergic to sesame, had bought a sandwich from Pret that had sesame seeds baked into the dough and wasn't labelled, because it used to be that if foods were made on site and then packaged on site, that they didn't have to write the labels of the allergens in the same way that you did if you went to a shop and bought it. And so although Natasha had made it clear she had a sesame allergy, the information wasn't passed on. She then ate the food and boarded a plane and sadly died of her allergic reaction. And her family have been instrumental in campaigning for this law, which is quite right to come through. So now all food businesses where you make something on site and package it also still have to follow the same other packaging laws of making sure that there's full ingredient lists. And that is in effect across the UK. People then often say to me, what do we do about the food labels that say things like may contain or made in a factory that handles nuts? What do they mean? So the first thing to say is that sadly, there's no standardized label that needs to be used to demonstrate the risk of cross-contamination. That's what this is about. So all of these labels mean the same thing, which is there may be a risk, but we don't know. Also, by law, you don't actually have to declare with a may contain label if there is a risk of cross-contamination. So some things that aren't labelled may be just as risky as some things that aren't. Reassuring things to know is that there have been no fatal reactions that have been described because people have eaten foods that perhaps they may contain and had a reaction, but there is still a risk that exists. And the advice that you will have depends on who you speak to, really, because different allergists do have different advice about it, which is not very helpful for patients. But, you know, that's one of the things with medicine and life. So I use some common sense in it, really. And that if you have a child like Flora who's never had any of the allergic reactions until the age of 7, the likelihood is she's been eating foods quite happily that have these labellings on it without any problems. And therefore for Flora, it's probably quite right that she could go on and carry on doing that. And then we used to say from Southampton, follow 3 rules, which were, if you have your emergency medicine with you, be that EpiPen or antihistamines, whatever you're meant to carry, you're in somewhere where like the UK, where hospitals are nearby, and you're well on the day, because you're more likely to have a severe reaction if you're poorly that day, then you could eat those foods that say may contain. Personally, I also have a bit of a caveat to that, in that foods like snack bars and chocolate bars, there are higher risks of contamination because of the way that these foods are made and the machines are washed. So I say perhaps don't eat snack bars that have these precautionary labels on, but you could eat things like, I don't know, a jar of bolognese where it's much less likely. For other people who've reacted to these foods before, then you're going to clearly say, don't eat them again. But if you are multiply allergic, then telling people to not eat anything that says may contain any of the things that they're allergic to can really limit their diet massively. So again, it's conversations to be had with patients, see what feels right to them and their family, and work from there. Should Flora be referred to an allergy service? Yes, absolutely, she should. These are the nice guidelines. So anybody like Flora who's had a systemic reaction would need to be referred, or who has those IgE-mediated food allergies and asthma, then they should be referred. If somebody has multiple food allergies, they need to be referred because they're going to need good help with management, with dietetic support. And equally, if the parents are suspicious of thinking about children, but you maybe don't think that they are, but you've done your best to explain why they're not allergic, but they're still cutting out food, it's just as important to refer those children on so that we can unpick that diagnosis and make sure that children aren't having restrictive diets unnecessarily. And often these children will come to light when they start school, and school say, if you want special meals for your child, you're going to need a letter from your GP. That's often the time that we as GPs become aware of these restrictive diets that some of these children are having. And sometimes there's good reason for that, and sometimes there really isn't. So please refer them on. If people have issues with their growth, so if they have IgE or non-IgE mediated allergies and issues with their growth, they should see an allergist. Non-IgE mediated allergies of the more mild to moderate sort should be referred to a dietitian. And finally, for the eczema group, for me, it would be if you have a young child with eczema, then it may well be appropriate for them to see an allergist. If you have someone with eczema who thinks that they have food allergies, of course, refer them to us. If you have a young child with eczema who perhaps hasn't eaten things yet, like peanut or egg, and families are concerned, then refer them. But if you have an older child or an adult who are just concerned that their eczema is not well managed, then really a dermatologist is going to be the right place to refer them. As I've said, if they're eating food groups without issues, we are not going to be doing allergy tests on those with eczema without good reason. Deaths from anaphylaxis, obviously when they occur, they are tragic, because the thought of somebody dying just purely because they've eaten something that should be harmless is awful. But thankfully, they do remain low across the world and in the UK, so around 30 deaths a year. So it is low, and sometimes we do need to put people's concern back in proportion, really, of saying, look, you are more likely to die from crossing the road than from this anaphylaxis, because anxiety with food allergy is massive. Other people, we need to make them sort of a little bit more concerned so they're not being so blasé about it, but sometimes it's useful to calm people down a little bit. But anaphylaxis rates themselves have massively increased. They've more than tripled in the past 20 years. And along with that, so have prescription rates for adrenaline auto-injectors. Does that mean that the deaths have stayed stable because the adrenaline auto-injectors are being prescribed more readily? It's difficult to know for sure. Children less than 5, they are much more likely to end up in hospital from their anaphylaxis, but thankfully death rate in little ones is incredibly low. And I also reassure families that deaths in a weaning infant, I actually haven't heard of any, so I think they are incredibly minuscule. So reassure families they should be feeding their children food and seeing what happens. As I've said, the teenagers, those young adults, are at the highest risk of fatal reactions, sadly. And also mentioned that now we are seeing more deaths from milk allergy occurring in children than nuts. Whether that's because people are more aware of nut allergies, take it more seriously than milk allergies, again, I don't know. Important things to know. So 2 myths that I hear a lot. So one, people say, if you've never had a severe reaction, it's not going to happen. Not true. Ethan always used to just have hives and vomiting and a bit of swelling, and then one day had anaphylaxis. Actually, it was the time that he had undiagnosed asthma, and the breathing was difficult to manage at that time, and that was when he had anaphylaxis. Other things that people tell patients is that your reaction gets worse each time you're exposed to the food that you're allergic to, and again, that's not true. We can't predict when anaphylaxis is going to occur. We know it's more likely in those older age groups. We know it's more likely in those with poorly controlled asthma, and if you're poorly on the day, but there are lots of other things that we don't fully understand. I've mentioned, really important for asthmatics to control their asthma properly from a point of view of their asthma and a point of view of their food allergy. What do you prescribe? So generally speaking, as a rough guide, I go off the 30 kilogram mark. So if you're 30 kilograms or approaching 30 kilograms, then I tend to give them the 0.3 milligram dose, but these are the specific guidelines for what dose to prescribe, which will be in the NF as well. And you may have heard, going back in 2020, the MRAs were all recalled, and that was due to concerns over activation failure. So they found that you needed a higher level of force than was recommended to activate the MRA pens, so they were all recalled. Now, since September, the 300 microgram and the 500 microgram doses are available after they've made some corrections, but not that smaller dose at the moment. So you do have several options open to you. The most important things to remember with adrenaline auto-injectors is, yes, you can prescribe them in primary care. People often ask me that. But if you are prescribing them, you absolutely should be training people on how to use them. And if you really didn't know, A, find out, but B, you can direct people to the product websites where they will, there are training videos on there that they and their families can watch to make sure that they know. And every time you do a new prescription, you should be checking that people know that they need to have 2 with them at all times, that they're carrying them everywhere that they go, and remind them of the training and the advice. And if you're switching between brands, make sure that they know how to use their brand, because they all have slight differences. Some just essentials. So they come in a little packet, you take it out, check the expiry date. There will be a window on all the pens, and you need to make sure that the fluid in it looks clear. And they should be kept out of extremes of heat, really, so not in the fridge and not in direct sunlight. And according to NICE guidelines and MHRA guidelines, they need to have 2 adrenaline auto-injectors with them at all times. So for adults, I prescribe 2. The teenagers, I prescribe 3, and that's 2 that the teenagers should keep with them at all times, and 1 to be kept in the school office, so that if they've lost their bag or their jacket or they've left them at home, then at least someone could run to the office for them and get that pen. For primary school age children, you need at least 4, 2 that need to be kept in school at all times, and 2 to be kept with the parent for the walk to school and back. You can't expect parents, particularly in COVID times, to be signing adrenaline auto-injectors into and out of school every day. The child can't carry them around school, so they absolutely need 4. Very occasionally I give 6 if the parents are separated and they are, having different people collect them each day, then that's a reasonable thing to do, but that would be the most. If they're going to brownies, they should be taking their pens with them to and from brownies. If they're going to swimming, to and from swimming, to and from grannies. So 6 would be the most, and only in those exceptional circumstances. These are the websites. Nice things to know, so patients can contact the manufacturers, as can you, and ask for training pens in the devices. They can sign up on them all for a reminder as to when their adrenaline auto-injector is due for renewal, to make sure they have their prescription. And the Jex one as well, I know, has an app that has training videos and help on there for patients. Reasons that they don't work. Commonest reason really is it's given too late. The number of people that tell me that they drove to A&E because they weren't sure whether their reaction was severe enough to use it, and then they waited to see. When you wait, you may just have a rapidly progressive reaction that just unfortunately then is fatal. If in doubt, use it. For a healthy individual, it is not going to cause harm. We all produce adrenaline when we're stressed, which is why sometimes anaphylaxis does get better on its own. The most it will probably do is put their heart rate up. So please, if in doubt, use it. So given in the wrong way, people sometimes don't use it. I've heard horror stories of where, because the parents were so used to training on themselves, that in the heat of the moment, they accidentally gave it to themselves. Sometimes, despite best efforts and using the adrenaline quickly, it was just a rapidly progressive reaction that was not going to get better in a community kind of setting. And that's one of the reasons that people die. The adrenaline injector being out of date is another common reason. And then also sometimes people who are on cardiac medications like beta blockers and ACE inhibitors, it blocks the action of the adrenaline, so it can affect how well it works. People ask me, well, should we not give those to people with allergy? It's a weighing up really of risk. And if you've got very stable allergies, you've never had anaphylaxis to, and the risk of reactions are low versus, unstable angina, then clearly it's better to look after their heart and then necessarily be too concerned about the adrenaline, but it's weighing things up. There are some, well, when anybody dies, of course, it's tragic. And as I said, because deaths from anaphylaxis are quite rare, then whenever somebody does die, then the case notes are always reviewed to see what can we learn. So in Natasha's case, when she died of her sesame allergy in 2016 now, only 15. A few things to highlight. So one was that when she was on board the airplane, she was asked to go to the bathroom to use the adrenaline auto-injector. As I said, that shouldn't happen. You should stay put and use your adrenaline there and not delay, because moving about can make the reaction get worse. It was also highlighted in the inquest that the second adrenaline auto-injector was given into the same leg. Now, there is no evidence saying that that would have caused a problem, actually. And is not in guidelines, and therefore that was not likely to have contributed to the death. But I can understand the science over why you would give it in the other leg. Most allergists do teach to give it in the other leg, and that's the learning that we can have from that. Samantha Singh was 26 when she died in 2020, so quite recently, from her nut allergy. And there was a whole raft of issues that had gone on, unfortunately, within primary care. So when she had allergy tests done finally with her GP, they were reported as normal to her. And it was only when she dug further that it was then transpired that no, they weren't normal. She didn't have follow-up arranged with her GP. She didn't have a referral made to an allergy clinic, which is usually recommended. And she only got one adrenaline auto-injector prescribed. Now, those things don't necessarily mean that somebody will die, but they do contribute to poor management of anaphylaxis when it occurs, to poor management of recognizing, how do you look after your allergies and prevent exposure? And they're important learning for us in primary care. As is the case of Shanta, who was 18 and died in 2018, again from a nut allergy. A few things that went wrong. So when somebody called 111 for her when she was having an allergic reaction, the wrong category response was sent, the wrong address was recorded, and at no point did the call handler speak to the patient, which is important, isn't it, to work out, what level of distress are they in, how does their airway sound, what are my concerns, and the 111 provider didn't make it clear to the person on the other end of the phone that they should have used the second adrenaline auto-injector if needed after 5 minutes. So there was training that went on within that. They then noted that the request that Shante had for adrenaline auto-injectors seemed quite erratic, that there was switching that went on. There wasn't documentation that she needed to carry two at all times. Even though she may have been prescribed two, it just goes to show that it was highlighted that nobody documented that they told her why she needed to carry two. She didn't have a training pen, and it was issues around this training that occurred, and that the GP didn't seem to be aware that she was at high risk of potential anaphylaxis because she was severely allergic, asthmatic, and a high BMI, and they were the sole provider, so she wasn't under an allergy service. So again, it's putting quite a lot of onus on us in primary care of recognising, if you're prescribing adrenaline auto-injectors, who else is involved in the care of this person? Whose responsibility is it to train in adrenaline auto-injectors? The answer is everybody's, really, and you need to make sure, therefore, it's happened. And this was flagged up in some more data, prescribing data results that have occurred. So this is data that we use when we're looking at prescribing, looked at in 2020. So still showing that still some people are still only having one adrenaline auto-injector prescribed at a time, which is against NICE guidelines and then OHA guidelines. And a third of people are carrying out-of-date devices. And then they recognise that over the last 5 years, there's been a switch to people being prescribed generic adrenaline auto-injectors. So just adrenaline auto-injector, 0.3 milligrams. Now, the reason for that is because there have been times that EpiPens have been difficult to get, checks have been difficult to get, and there was one period where they were all very difficult to get. So we were told, even in allergy clinics, prescribe it generically, and the pharmacist will just give what it has. Fine, but then what are you meant to be training on? The patients don't necessarily know. How you use the Emerade is very different from how you use an EpiPen, and that can all add to issues. So really, we should be prescribing by brand. And if we can't, for whatever reason, asking really the person to come back for training. And then when we looked at a GP survey of asking about adrenaline auto-injectors in 2021, many GPs recognised that they weren't confident, A, in themselves, but B, in the patient's ability to use their adrenaline auto-injectors. The key message that came out really is that everybody felt it was somebody else's job, that people often felt that it was the job of secondary care, whereas secondary care may well thought it was the job of primary care because we're often the ones issuing it. Some people might think it's the job of the pharmacist, which often doesn't happen. Shame, because I think pharmacists are really well placed actually to be giving training on adrenaline auto-injectors. So when they're giving out the pens, they could just give quick reminders. And there is a push for that, but it's not the case everywhere. It's often just pharmacists who've got an interest. Talked again about the switching. It's just important, whatever pen you're giving, every time you issue a prescription, because they're only needed every couple of years, please just give a 2-minute phone call with a quick, this is how you use your pen. How is your allergies? Do you need it? It should prompt medication review really, because they're issued so infrequently. Okay, moving on briefly now just to vaccinations. So the Green Book about vaccination says that for us to be prepared for anaphylaxis, that we should have adrenaline ampules really of 1 in 1,000. And normally it's recommended that if somebody's having anaphylaxis from the vaccination, that we would specifically draw up the adrenaline to give it. Now, I don't know about you, but I really don't know as a GP when the last time I drew up adrenaline. I would probably feel a bit anxious about it. Oh God, have I got the right dose? Is it the 1 in 1,000, 1 in 10,000? Which one am I doing? It's much quicker, easier to get an adrenaline auto-injector and to give that. And actually, it is recommended if that's what you've got on site. It's absolutely fine to use that. It is adequate. It just kind of traditionally, it was always that you had the ampules really, but you absolutely can use the adrenaline auto-injectors if you have them. They are all available and in stock at the moment, so that's good information to know as well. And you should use them at the first sign of anaphylaxis. So even if someone was just coughing, that is anaphylaxis, give the adrenaline straight away. We always feel a bit nervous about giving it. If you look at audits into how often do we give adrenaline for anaphylaxis, we always perform poorly, to the point that the resus guidelines have changed now. So they've taken off antihistamines, they've taken off steroids, because first line treatment for anaphylaxis is adrenaline. So give it straight off. The reasons that the dosages are different for adrenaline auto-injectors versus if you draw it up, because if you draw it up for an adult, it has to be 500 micrograms, whereas if you give an adrenaline auto-injector, 300 micrograms is absolutely sufficient for any size adult, is because about the way you're giving it. So a needle and a syringe is a different technique versus an adrenaline auto-injector, where it's that automated technique which will deliver it better and more efficiently. And that's why you need the lower doses from it really. So please do use them. COVID vaccinations. So the main ones that we obviously have in use that we're using are the Pfizer, Moderna and AstraZeneca. But those are the main ones that I've still seen, although I know there are others. And there is a higher risk of anaphylaxis with the Pfizer vaccination, about 11.1 per million as opposed to the flu, which is about 1 in a million. So much higher risk of anaphylaxis. And the Pfizer and the Moderna vaccinations both contain polyethyl glycol, or PEG for short. And we've all learned more about PEG as these anaphylaxis episodes occurred when the vaccinations were rolled out. Now, it's a group of allergens that are mainly found in things like household products, cosmetics, and in lots of medicines. So people with a proper PEG allergy will have had anaphylaxis to multiple things usually. So usually multiple classes of drugs and possibly even cosmetics. And they will either know that they've got a PEG allergy, but it is quite tricky to diagnose, and many people will have unexplained anaphylaxis. So if you have an individual with a PEG allergy, they absolutely can't have Pfizer or Moderna. Or if they describe proper anaphylaxis to several classes of drugs, they can't have it. If you have unexplained anaphylaxis, they can't have it either. It needs an allergist's opinion. Or often the biologics, if they've had anaphylaxis to those, then again, they shouldn't be having the Pfizer or the Moderna. The AstraZeneca can be used instead, but now it has to be given in a hospital setting. So you need to refer them to the hospital and they need to be monitored for half an hour. So really, if you have somebody where you've got concerns, they need to be referred to an allergy specialist. The other slight confusing thing for us is that AstraZeneca contains polysorbate 80. So some people have a PEG allergy will also react to that. And one of the ways we may well know is that these individuals may have reacted to the flu vaccination before, because it is used in the flu vaccination, which is given to the over 65s. So if you've got somebody who's had a proper reaction to a flu vaccination, then again, ask an allergist for advice. Okay. And of course, if you've had somebody who's been given the COVID vaccination and had a proper systemic reaction, then we're not going to be giving that in primary care. We need to ask an allergist for advice. So here's a traffic light symptom system. Some of the confusion comes is that when the COVID vaccinations were released, when people started having anaphylaxis, then to be safe initially, they said, please don't give it to anybody who's ever had anaphylaxis, including to food and wasps and bees and things. And that was just while we were looking into it more. Now we know that people with food allergies, people with allergies to like a single medicine like penicillin or to insect stings can absolutely have any of the COVID-19 vaccinations without issue, okay? So they don't need referring on, you can just give them, and we will need to give a lot of reassurance to families, and we still are at the moment giving it to patients because they heard that you couldn't have it if you had anaphylaxis to food, and that message is still actually coming through. Then you've got this amber category, so anybody who has had these concerns that maybe there's a PEG allergy, as I've just gone through, or spontaneous anaphylaxis, and you don't know why, they're going to need to see an allergist. Or if they've had COVID-19 vaccination and you're not sure about what reaction they may have had from that, again, you might need to ask an allergist to see what they say. Often they get some antihistamines before the vaccination and then monitored for longer, but given in a hospital setting. And of course, we're not going to give it if they've got PEG allergies. You can ask an allergist to do that. If they've had a systemic reaction to the components of the vaccination or the actual vaccination itself, then again, they're going to need an allergist involvement. And another bit of a flow chart for you. So the easy end, have the symptoms begun quickly after vaccination? Yes. If they've had anaphylaxis, we're not getting involved. We're going to refer them to an allergist. Bit in the middle of it wasn't anaphylaxis, but they had some systemic symptoms, and it says we could give another vaccine again, but observe for longer. If in doubt, ask an allergist. They are there readily available to ask, particularly around concerns around vaccinations. And if you've just had the COVID-19 vaccination and had a delayed then localized urticaria or angioedema at the point of the site of the vaccination, then they actually can have the vaccination again in primary care. But we just need to monitor them for longer, just in case that was the first sign of a potential problem. Second time, it might be that they have anaphylaxis. So you need to monitor them for half an hour. But anybody else, as you can see, if you're less concerned about the reaction, if it was self-limiting, you can have the same vaccine again. But if in doubt, ask an allergist. And then my last bit on egg allergies and flu vaccinations. So most flu vaccinations, they're intramuscular and they have very low doses of ovalbumin. You can get some that are completely egg-free. So those are the names of it, Fluzilvax, Tetra, and Supentec, if I could say that rightly. So they're egg-free. So they're prepared in cell cultures. Any concerns about severity of egg allergies, then you give them those. The nasal flu vaccination for children does contain egg, but there was a large study called the Sniffle study that included everybody apart from children who'd ever been intubated on intensive care because of their egg allergy. So not many, and that was because of ethics. And they were all absolutely fine. So children with an egg allergy can have the nasal flu vaccination unless they've had a particularly significant egg allergy reaction, in which case ask secondary care. So in summary, history is absolutely vital in correctly diagnosing IgE and non-IgE mediated allergy. And if you have IgE mediated allergy, you can confirm that with testing. For non-IgE mediated allergy, it's about taking the food out for 2 to 4 weeks and then retrialing it to confirm your diagnosis. Prescribe adrenaline auto-injectors appropriately, but please always give people 2, and please train them at every opportunity. Review the prescriptions regularly, train them regularly, be the person to take responsibility, because otherwise perhaps no one else will. And if you're in vaccination service, if you're involved in COVID vaccinations, flu vaccinations, then please read your green book regularly before you do a clinic. It changes all the time. Every time I look at it, it's changed again because we're learning so much more about the COVID vaccination. So please just always have a quick look. Has anything changed from what I've just told you there? Thank you very much. If you have any questions, please feel free to contact me on email. If you have patient details, use my NHS one. If it's just a generic, how do I get into allergy, which lots of GPs ask me, then drop me an email and I'm happy to help. Thank you very much. And then these are just some extra resources as well that I'll leave you there from the anaphylaxis campaign.